Hello, everyone, and thank you to our organizers for having me today. My name is Paula Brady. I'm one of the reproductive endocrinologists at Columbia University in New York City. I'm our director of Oncofertility, and I run our fellowship training program there. And today I'll be discussing what matters to clinical leaders and decision makers. I've been invited here because Columbia has proven particularly able to get insurance to cover urgent fertility preservation cycles, and so I wanted to share some of the ways that we've been able to do that. Um, so a little bit of background. We're an academic fertility center. We do over 2,500 cycles retrievals a year. In 5 years, I've seen at least 500 consults and done at least 150 treatment cycles. And our program, our oncology program, really relies on a specialized team. We have our own coordinator who receives the referrals, schedules them, and helps patients navigate the philanthropic grants. We have a program coordinator who also handles the medication prior auths and generally guides patients through the process, checking in with them and so on. And very importantly, we have a financial specialist with years of experience in getting quick prior authorizations for patients with cancer. A defining fact is that Columbia takes most commercial insurances for infertility care. And so that's part of a commitment on part of the university and our OBGYN department to support patient access as much as possible. And so those contracts and terms are negotiated at a level higher than our division, but it's important context. So quick look at our workflow for patient care. We receive the referral and that patient is usually scheduled within 72 hours. I basically just fit them into my schedule wherever I can. We have a third-party benefits verification team who generates their insurance benefit report, and the patient is emailed an explanation of their benefits by our financial specialist prior to their visit and can also talk to our team on the phone before they're even seen. And that information is also in the electronic medical record, so I can review it with the patient during their consult and kind of explain what to expect for the financial process. Then right after the visit, I put in my consult note and talk to our financial specialist. She knows how to expedite requests to various companies. And so these are sort of the hints that she gave me about the various plans. And then, which is a combination of portal submissions, calls, and emails. For her submission, she'll need my consult note and the oncologist note. If the patient referral came without oncology notes documenting the diagnosis and planned treatment, our coordinator knows to go back to the oncologist and request that and upload it to the system. After the visit, I provide the ICD-10 codes, which are always the Z31.84, which is Encounter for Fertility Preservation, and also a C code. These are the cancer ICD-10 codes. So for instance, like breast cancer is C50.91, and each cancer has its own code. They're Googleable. And I've been instructed by our financial specialist to provide as detailed a C code as possible. That gives us the best chance of getting it covered. So like side of a breast cancer. So 50.911 is right-sided breast cancer, that kind of thing. New York also has a fertility preservation mandate for private insurers, which is very helpful in all of this, but many plans are exempt because the employer has to be based in New York, have at least 100 employees, and various other things. So there's lots of plans. There's many patients who come in saying, I know about the mandate, so I'm covered, and then it doesn't apply to them because of their employer. So I've been asked to talk today about how we got buy-in from clinic leadership to do all of this. And thankfully, our leadership at Columbia and the division puts patient care first and supports our physicians' professional goals. But medicine's also a business, so essentially I built a busy clinical IVF practice as quickly as I could. New York is a high volume setting. But I was also given autonomy. So I block time in my daily schedule, 8 to 9 a.m. for urgent consults to be slotted in. And if I have cancellations, I often don't fill them in case other urgent consults come in. Our clinic leadership doesn't nitpick our physician schedules, which is definitely not true at every practice. We're given autonomy to manage our time in a way we think is most productive, which is really important to making this all work. So I basically have a busy infertility practice, and then those revenues support the salaries of the staff of my other team. And then our oncology team members help out on a few other clinical physician teams as needed for cross coverage. So they also support the practice as a whole. So scaling up in that way has really been a key point to making this all work and kind of work for leadership too, that's looking at the business side. So then in terms of future directions, and these are kind of my policy recommendations, which I know many other presenters today have and will discuss. We need more insurance coverage. There are efforts in New York State, the New York State Assembly, to require public insurance to cover fertility preservation, which we're very excited about. We also need coverage for non-oncologic treatments that damage fertility, so such as stem cell transplants for sickle cell anemia, which is classified as a benign condition. So they don't qualify for most philanthropic grants and a lot of these mandates because it's technically not cancer. And then we also, as many folks have said, need to make sure that patients with cancer are being counseled and referred for this care in the first place. On my part, that involves building relationships with local oncologists and providing lectures to area programs and trainees to build awareness. This also includes conducting and publishing research, attending conferences, and training our fellows to provide this care and to understand the importance of it. And all of which I'm given time in my day by clinic leadership for the reasons that I stated earlier. And so that's really my research question too, how to improve awareness and referrals for this. So that's actually all I have today. So thanks for having me, and feel free to reach out afterwards for any questions.